Well, lovely. We've got lots and lots of people registered for today, so I'm sure, I hope people will be joining us. But whilst people are coming in, we might just kick off. So lovely to join with you today. I'm Sharon Friel, Director of the Planetary Health Equity Hothouse, and joining you today from the lovely lands of the Ngunnawal and Ngambri people. And of course, I want to acknowledge the First Nations people on the various lands that we're coming to from across Australia and beyond, and pay my respects to our elders past and present, and to our Indigenous colleagues joining us online. So as you know, in the Hothouse, and what we like to do through these the Saving the World webinar series is really have a discussion about some of the big structural issues that are contributing to planetary health inequities. We refer to that as the inequitable enjoyment of good health. Well, planetary health equity is the equitable enjoyment of good health in a stable Earth system, which of course is not what we're experiencing today. And there are many forces within this global consumptogenic system, this system of policies, of institutions, of different commercial activities, a whole range of different actors and interests and norms that are really working very hard to create this system based on, it's a system of extraction, of excessive production and consumption of fossil fuel goods and services, which of course are destroying the natural Earth system, contributing to poor health and inequities around the world. And our big question within the Hothouse is, what are the conditions that can change that system? And so I'm delighted to be joined today by an old friend and colleague of many years, Professor David McCoy. Dave, as you'll have seen from his bio, Dave is currently the research lead at the United Nations University, the International Institute for Global Health, based in Kuala Lumpur in Malaysia. And Dave really has been a leader. He's a public health specialist, has been at the forefront of both the intellectual discussions, the practice activities, and the civil society movement building around global health inequities. And in his current role at the UNU, really sort of pushing us to think about global governance for health, issues of accountability, and of those big, strong sort of corporate actors in particular that are trying to advance their interests, which of course are not always often aligning with global health. So it'll be fantastic to hear from Dave. And then to just sort of kick us off with some questions is my great colleague, Dr. Desh Gadril. Desh is one of the laureate research fellows. He's a political economist and is leading the work here in the Hothouse around how paradigm shifts actually happen, which of course is fundamental at the core of how do we transform this consumptogenic system. So we'll hear from Dave for about 20-25 minutes or so. Desh will kick us off with some questions, and then as always we'll come to the audience for Q&A as well. So please get your questions stored ready to engage. So with no further ado, Dave, I'll hand over to you.
Great, thank you, Sharon. It's really great to be here. Can I just check that my slides are coming through?
Perfect.
In the right moment?
Perfect.
Yeah? Okay, great. So I'm hoping I won't speak more than about 15 minutes, because what I really want to do is just set the scene for some of the work that we're doing at UNU-IIGH. But I'd really value a lot of conversation from this session, and to get input and ideas about the work that we're doing from you and others in the audience. So essentially what I'll do is simply present the work that we're doing, and hopefully we can then have more of a discussion after that. So I'm going to present one of 4 packages of work that we're doing at UNU-IIGH. And this is a slide showing our current 5-year strategy. And you'll see that the overarching mission of the Institute is to reduce health inequalities globally. We have a mandate to look at global health through the lens of the Global South. So there's a particular focus on global inequalities and looking at health challenges in low and middle income countries. We have these 4 work packages, of which one is on power and accountability, and that's the work package that I lead and head up in what I'm going to describe in the conversation today. But the 3 other work packages have intersections with power and accountability. One in particular is looking at digital health governance and security. And we've also got a work package on climate justice, which speaks very much to issues around global governance. And then the other work package is on gender equality and intersectionality, which is much more focused on what goes on within the healthcare system. So it's a little bit more removed from issues around global governance. But nonetheless, that provides you some context of what we're doing at the Institute. And just in case people aren't familiar with our Institute, UNU, United Nations University, is a formal part of the UN system. So we're a formal UN agency. It's headquartered in Tokyo, and it's made up of 14 different institutes that are spread across the world, with each institute focused on a different topic or a different theme. Our institute is based in Kuala Lumpur, and obviously we are focused on global health. We are called a university, but in actual fact, that term is really used to designate the academic function that we have within the UN system. But we don't operate like a traditional university. We operate much more as a think tank or a policy research institute. So just a little bit about the background to this work package. In fact, a lot of it emerged from work that had been done in the previous 5-year strategy, where there'd been some discussions and some attempts to convene conversations around the agenda to decolonize global health. And when I got involved with these initial conversations, one of the things I tried to do was to expand the conversation around decolonizing global health to include, greater attention to contemporary forms of colonialism or neocolonialism. Much of the conversation in global health at that time was centered around historical colonialism and some of the legacies from the previous empires of Europe and their impacts and the continued impacts in the global South. And what I wanted to do was to expand the conversation to include the current forms of colonialism, the current forms of exploitation and extraction, much of which is driven and generated through a globalized system where the key actors are financial actors and corporate actors, transnational corporations. And of course, nation states are very much part of the architecture of contemporary colonialism. But much of contemporary colonialism is driven through global structures and global systems operating through a kind of deterritorialized system that operates across national borders. And so that's kind of how we ended up thinking about power and accountability and building a program of work that was focused on global health governance, but looking specifically at issues around the way in which systems, economic, political, and social systems at the global level were facilitating extraction in ways that could be described as neocolonial and facilitate systems of exploitation and driving resource concentration amongst a tiny few and leaving the majority of the world's population either in conditions of poverty or conditions of precarity. And of course, I think the environmental dimension was an important element of this, and thinking how not only are contemporary systems of extraction and exploitation affecting populations today, but they're also affecting future generations in the sense of harming the environment in ways that will deplete resource availability for future generations. So that was some of the background. And as I said, we started off by this framing of looking at power and accountability. That was the framing of this work package. And starting off with the recognition that currently we live in a world, in a system where there are huge inequalities in power. And as a result of that, that is affecting the way in which systems of governance operate. So one of the first things we did with this work package was to try and relate this topic of power and accountability to global health governance. And this is a briefing paper that we published last year, what we describe as a foundational working paper for this program of work, where we attempted, first of all, to define what we mean by global health governance. And this is the definition that we use in this working paper. We're talking not just about the formal structures, institutions, and systems at the global level, but also the informal structures, institutions, and systems through which actors make decisions about global health standards, policies, and priorities, through which these actors finance, organize, and implement global health initiatives, programs, and plans. And then importantly, thirdly, it's the mechanism by which actors also influence and engage other actors. So this is global health actors influencing and engaging with actors, systems, and institutions that lie outside of the health sector, but which have an impact on health. So we basically adopted a very broad definition of global health governance. And within this, we were kind of emphasizing the duty, the responsibility, the mandate of global health actors to look outside of the global health sector, to also look at the way in which the global economic system, for example, is governed. And this is kind of represented in a diagram that we published in this report, contextualizing global health governance within this wider system of global governance, and looking at the way in which global health governance also interacts both with international politics and with politics at the national level. So having described and defined global health governance, the next thing that we wanted to do was to be very clear about the kind of global health governance that we want to see. What do we mean by good global health governance? And of course, this is a normative statement that we are making here. And we wanted to be very explicit about the kind of global health governance that we want to see. And here we define this in two ways. First of all, good global health governance is governance that manages to achieve certain defined outcomes, what we want good global health governance to achieve. And here we are talking explicitly about improving global health efficiently, effectively, and equitably, with a strong focus on reducing social health inequalities within, between, and across countries. So that's the what. But also we wanted to be explicit about good global health governance needing to be also about good processes of governance, that we want to define global health governance in terms of how governance should operate and be conducted. And we're emphasizing here processes and practices that are procedurally fair, inclusive, and consistent with democratic values. So we're being very clear and upfront and explicit about about what we mean by good global health governance. And again, trying to be a little bit more detailed about what we mean by this. Yeah, what we mean by the kinds of values that we use to define good governance. And when we started discussing this and thinking about this within the program of work, we started off by thinking about good governance at the national level. And here, of course, most people would define good governance in terms of being anchored in democratic values and principles. And when you think about good governance at the national level and think about democratic principles and values, and you think about values that are about equity and about inclusivity, you immediately start thinking about democratic systems. And we started our conversation about defining good global governance by trying to define what we would mean by good governance at the national level, and recognizing the importance of democratic systems, democratic processes, but also all of the, I suppose, the ingredients for what would make a democratic system actually democratic. And here we're really talking about norms, customs, and ideas. And we're really talking about institutions at the national level that buttress good democracy. So essentially what we're trying to do is to push the definition of democratic governance beyond simply having democratic elections every 5 years, to including having at the national level institutions that protect free and independent journalism, for example, having institutions of higher education that champion academic freedom and have a mandate to encourage informed public debate, and of course, having a healthy civil society. And we did all of this because we had to then translate all of this discussion about what makes for good democratic governance at the national level to the global level, where, of course, we do not have a world government, we do not have a world state, and therefore we do not have democratic institutions and processes that exist at the national level. And so, of course, we spent a lot of time in our briefing paper thinking about, well, how do we, what makes for good democratic and accountable governance at the global level? Given that we don't have democratic elections at the global level, and given that we have to operate through national governments representing their populations at the global level. So I won't say any more about that. Maybe some of this will come up in the conversation, but that's kind of what we've covered in this briefing paper. What we also did in this briefing paper is to highlight, emphasize the importance of power, and that that governance systems, whether at the national or global level, are always mediated by the distribution of power across different groups and different interests. So the distribution of power, the way in which actors accrue power, the way in which they deploy that power through systems of governance, ultimately affect the way in which governance is practiced and the way in which governance produces outcomes. And what we wanted to do in our work package was to have this focus on power and power dynamics, distribution of power, but to also have a focus on the concept of accountability itself. And we see accountability as being one of the ingredients of good governance. And we also see accountability as one of the mechanisms by which we can try and address the problems of power imbalances, or the problems of there being a maldistribution of power across different actors. If we can focus attention on holding powerful actors accountable, this is one mechanism, one way in which we can seek to rebalance existing power imbalances and asymmetries in the system. So we spent a bit of time looking at how we define accountability. And what we tried to do here is effectively to expand the definition and conversation about accountability beyond transparency, and to include, for example, systems that would enable for a sanctioning of actors or institutions when they fail to meet expected standards of behavior or performance, and to also emphasize the importance of remedy, restitution, rehabilitation, compensation, and corrective action as being part of a definition of accountability. So those are the fourth and fifth bullets there, which tend to be ignored or neglected in conversations about accountability. So I'm going to rush through because I'm trying to get through this as quickly as I can so we can get to some conversation. But just to emphasize now that when thinking about global health governance, that's very broad. It's a big topic. And so we decided also to focus in on a set of particular actors within the global health, or within the system of global health governance. And here, based on an expert group meeting that we convened in Oxford in 2023, we decided that we would focus our attention on powerful private actors within the system of global health. So look at how these actors impact on the system of global health governance, and to look at how these actors can be held more accountable. And so that's become the focus of our work program. And this is a work program which has a 5-year kind of time frame. And we're currently in the second year of that 5-year strategy. We have tried to justify the focus on powerful private actors by looking at the history of these actors in global health and looking at how these actors have been referenced in the past in global health literature, drawing on some of these kind of seminal I suppose milestones in the history of global health, the Alma Ata Declaration, the Commission on the Social Determinants of Health, for example, trying to draw links to the current interest in the commercial determinants of health and this growing body of literature that's being produced under that theme. And over the last 18 months or so, what we've been trying to do is to build the foundations for a program of work. And those foundations have included some specific areas of research. So, for example, one of the streams of work that we've been conducting has been looking at existing and current forms of corporate accountability. And here we've settled on looking at two existing instruments that have been set up and designed to hold pharmaceutical corporations and food companies accountable for their impacts on global health. And these are the Access to Medicines Index and the Access to Nutrition Initiative and its Index of global corporate performance. And essentially, these are two instruments that are set up to rank the biggest 20 pharmaceutical corporations in the world according to how well they perform to improve access to medicines in low and middle income countries. And then secondly, an index to assess and rank the 30 biggest food companies in terms of their performance to improve healthy food, access to healthy and sustainable food. And essentially what we've done is to critique these two indexes and to actually conclude from our analysis, we're making the argument that these indexes, in fact, instead of actually helping to hold these big corporations accountable, actually have a perverse impact. They actually reinforce the power of these big, powerful companies and undermine other efforts to hold them accountable. And in fact, so they actually have a perverse impact. And I won't go through the details of this analysis, but just to give you a flavor of some of the work that we've been trying to do. So there's a big focus on looking at corporate power and their accountability. So that's part of what we're doing. Two other areas of work that we've been developing has been around financialization and looking at private financial actors. And these are actors, we're talking here about hedge funds, we're talking about private equity, we're talking about asset managers, we're talking about banks, and we're talking about their role in the financialization of health, including the financialization of healthcare systems, where we're seeing the emergence of corporatized forms of privatization of healthcare systems. I mean, this has been happening for decades in the US. It's been happening increasingly in Europe, but the important point here is that it's becoming a phenomenon that we're seeing particularly in upper and lower middle income countries. And so that's an area of work where we're trying to look at the accountability of these private financial institutions and their role in driving forms of privatization and corporatization that we feel are having harmful effects on patients, but also having a harmful effect in terms of driving even further healthcare inequalities across the world. We've also been looking at policy instruments that can help to reduce inequalities and help to constrain the power of powerful private actors. And here is another briefing paper that we published this year, looking at the critical role of tax systems and tax policy, not just in terms of generating revenue for healthcare, but more importantly, the role that tax systems play in terms of ensuring good governance, in terms of redistributing the inequalities in power and economic resources that we see across both the global systems of governance, but also at the national level. So just to give you a flavor of some of the work that we're doing in this work program. We're currently in the process of publishing 3 other papers, briefing papers, to look at other types of actors, transnational accounting and consulting firms. Here we're talking about the big 3 consultancies, McKinsey, Bain, and the Boston Consulting Group, who dominate the consultancy, the consultancy market in global development, but also in global health. And the big 4 accountancy firms. Here we're talking about KPMG, Deloitte and Touche. And again, these are 4 accountancy firms that dominate the way in which both governance, but also other powerful actors operate within systems, within economic systems and political systems globally. They have a huge influence in shaping not just public policy for health and development, but also public policy in terms of how powerful private actors should be governed and held accountable. We're looking also at a briefing paper at the policies across the UN system in terms of how different UN agencies engage with private actors. And of course, this includes the FENSO agreement which WHO has, which helps to shape and determine the ways in which WHO engages with private actors. And then thirdly, looking at the role of private foundations and for-profit philanthropy. So this is, again, a set of actors that has a huge influence in global health, but also a huge influence on public policy and the way in which global health governance systems are designed and govern themselves. So we're essentially trying to map out the terrain of powerful private actors in global health. And this is work that we're trying to do in the first 2 years of this 5-year strategy, with the intention being that in year 3, 4, and 5, we will be spending much more time, not just mapping the terrain, but actually working more closely with actors who are engaged in the policy process and engaged in governance on a day-to-day basis, including governments, but also civil society actors, to see how we can use some of this research to actually shift policy in the direction of redistributing power and economic resources and correcting the accountability deficits that exist with many of these powerful private actors that I've just mentioned. So I'm going to stop there, Sharon, and I hope that's given enough background to the work we're doing, but more importantly, giving us enough food for thought and food for conversation.
Yeah, no, that was brilliant, Dave. I'm sure there'll be lots of questions, and just from the people whose names I recognise in the participants list, there's lots of synergy as well. So hopefully that'll also create some opportunities for afterwards, and you'll be bombarded with people wanting to connect. That's brilliant. So I might just hand over to Desh. Desh is going to kick us off with just a few questions, and then colleagues, please, your questions, your comments, either in the chat or just put your hand up, and I'll come to you once Desh is finished. So Desh, over to you.
Thank you, Sharon. Yeah, David, that was quite amazing. So clearly there's lots of work that you guys are doing at the moment on powerful private actors. One thing I wanted to, I guess, start with in terms of questions is in the 21st century, there's this new kind of capitalism has come about, which a lot of people are calling financialized capitalism. It's somewhat different from what came before. Some people have called it managerial capitalism, where now the role of financial actors, whether it be in the stock market or through hedge funds, etc., and even the growing importance of the financial sector itself.
Yeah.
All of that is playing a much bigger role in the global economy, global political economy. So we've gone from what used to be profit maximization to what is now short-term shareholder value maximization, which is a much more short-termist and has more of an immediate kind of impact on a lot of the things that corporations do as well. So whereas it used to be managers that control corporations, it's now the shareholders and then hedge funds that do that.
Yeah.
So how do you think this changed from the previous type of capitalism, I guess, to the more financialized forms of capitalism that have appeared? How has that, do you think, translated into this space where powerful policy, private actors impact global health?
Yeah, it's such an important question, Tridesh. And, I've actually been on quite a steep learning curve myself in trying to understand, just how transformative this shift from what people call the Washington consensus to the Wall Street consensus, and how financial actors have become so dominant and so powerful. As you say, it's financial actors that are now driving corporate actors. So, these are the actors that kind of exist behind the curtain, as it were, pulling the strings of many transnational corporations. And a really good example of this was the chief executive of Danone, one of the biggest food companies, one of the food companies that is ranked by the Access to Nutrition Index, headed up by a chief executive who tried very hard and genuinely with, kind of genuine goodwill to shift Danone's activities towards producing food that was sustainable. And he was essentially sacked by the shareholders, who felt that he was a threat to their short-term profit maximization. And so corporations have become ever more aggressive in their profiteering and ever more short-termist in their orientation, because of this transformation, because of this financialization. And so one of the things that we have realized is that actually there's very little understanding in public health about this transformation. There's very little taught in public health programs about financial instruments, about financialization in general. And yet these are the actors and these are the instruments that are now becoming incredibly important.
Mm.
And I was at the Seville Financing for Development meeting, and the big narrative across the SDGs now is that there isn't enough public finance. And there are these huge public financing gaps, and we need to fill that gap with private capital. And of course, this is a very dangerous narrative, and it's an uninformed narrative, because there are alternatives. There are ways of filling that public financing gap. And the problem isn't just about the financing gap. It's also about the relative amount of private money compared to public money. And one of the most important graphs that I've seen recently is the graph showing the amount of global public wealth against the amount of global private wealth. And you can see over the last 30 years that the ratio between private wealth to public wealth has grown hugely, and it's continuing to expand. And this is the fundamental problem. It's the ratio of private money to public money. And that's grown because of the deregulation of the financial sector that's happened over the last 20 years. So to prevent this, we need to re-regulate the financial sector. That is the solution. And we need to bring the global health voice to that argument. Yeah.
Thank you for that. Relatedly, I mean, you touched on this point as well, and I think it's kind of the elephant in the room too, in many ways, is how the funding landscape has changed recently, and how there's this big hole, and this gap that you were talking about has gotten even bigger to very problematic levels. And it's a perfect opportunity for a lot of powerful private actors to fill that space and increase their influence, which they will, of course, want to do and will be looking to do. So how do you see things playing out at the moment? And are there any kind of things to be optimistic about, or is it just, pretty much doom and gloom?
Well, I think it's important to think about this concept of filling the gap, filling the financing gap. I mean, the first thing that we should be emphasizing when we talk about filling the gap is talking about redistribution. So a large amount of that gap can be filled by redistributing wealth. And this is why tax is so important. This is why the UN Tax Convention is absolutely vital to low and middle income countries, because at the moment we have a broken international banking and accounting and tax systems that is allowing hundreds of billions of dollars to flow out of the poorest countries into tax havens in the global north. So we have to talk about redistribution. The second thing is that we have to look much more critically at the way in which the financing gap has been calculated. I think these gaps have, to some extent, been exaggerated in order to create almost a kind of rationale for bringing in more finance capital. And I think we can do a lot of health improvements at low cost. We need to go back to some of the earlier conversations we had in global health about good health at low cost. And particularly now with the environmental crisis that we're facing, we have to be also thinking about good health, based on energy that is not going to further destroy the environment. And there is a connection between good health and low cost and good health that is sustainable and not dependent on fossil fuels. It's important to make the point that there is a financing gap, there is a public financing gap, but that can be filled in ways that does not require us to be reliant on private finance capital that expects and often demands a double-digit return on their investments in terms of profit. So these, what we're seeing is rhetoric, which is essentially inviting private capital into places which are expected to then generate profits for that private capital.
Mm.
And we're still seeing public money being used to de-risk that private investment. So we're seeing a diversion of public resources also away from expenditure that would be more useful in many of these settings in order to attract that private investment, which has the potential to be actually exploitative, extractive, and destructive.